start with the series 6, which is the last of the 5 A's, that is assess. And what we are going to do is use some case studies. And for this, we are going to take some examples of certain articles which have been published. The most important thing which we generally do is look at populations, and in populations we do take into consideration the percentages and proportion. The article is by Underwood and Fox on alcohol and drug abuse among dental students, presented in the British Dental Journal. The aim was not very clear basically, because it didn't tell us whether it was all the dental students of that particular country, but ultimately we found that it was only one particular college. The primary characteristics were smoking and non-smoking, and the secondary was on alcohol and drug abuse, which was prevalent in the students in that institute. A prevalence study is generally also called as cross-sectional study, and it is generally done by a survey. The attributes, habits or opinions are the events which we record either by telephone, face-to-face interview, sometimes with email. In this particular article, the survey was done by going to each class and getting the questionnaire taken and kept in a box without the student name, so anonymity was kept. Normally such surveys are very difficult to do because the response rate is very less than 25%. But if you go to a closed atmosphere where there are college students and you go there and do it, then the response rate becomes better. And that is why in this particular article the response rate was very good, and that is why it was applicable to all other results which were given. A random sample of students was taken by using a standard frame. The prevalence and the number of people characterized at a particular point of time was taken and expressed as a percentage or proportion of the population of interest. This was repeated every year so that the same students were being followed in the 4 years, and that is why this was very comprehensive, because the changes which takes place in their characteristics could be tabled and could be evaluated or compared. And that is why this particular article is very good, because it is following the same population for a longer period of time, and that's why the results are comparable, and you can find correlations, you can find associations with this. The results of the study, first we'll take is tobacco. The table 1, which was not given but it was prepared both for males and females, and it was found that the prevalence of smoking in the 4th and 5th year was 21. That means the males who were present in the 4th and 5th year had in the past or are currently smoker with 21% of the students being doing that over a period of time. If you take the table, then you will be able to make out the different prevalences rates which are there. And when you do both in the males and females, you can find out the gender difference. You can also, when you do it in the first 3 years and then the 4th and 5th year, then that comparison between the years taken place. For example, males were smoking much less in the first 2-3 years, but increased to 21% in the 4th and 5th year, whereas in the females also the same increase could be seen. So the number of students and all, you can get an average of all the students at the same time, which was 0.08%, 0.08 or 8%. So this is how tabling and everything is done, and you have to find, when you are evaluating the article or when you are trying to apply it to your patient, you have to do that. Secondly, you can have this graphical representation, so you can easily make a conclusion that in the first 3 years it was within limits, but then it became higher. and binge drinking was possible. Binge drinking was done in every Saturday and Sundays. Now, if you see that, guys, you can find that they are also using drug. Cannabis was being utilized, and the frequency of use and the prevalence could be then calculated from this table of both the males and the females of the students. The comparison between groups can be done, and that comparison generally, when we want to do it, we have to understand that in evidence-based education system, the prevalence difference between groups is called as the risk. The risk in first year and risk in fourth year, and that risk ratio is taken into consideration. This gives you the cause and effect also, and the risk also, and whether it is therapy, whether it is harm or prognosis, risk is the most important part. As you can see here, the risk of the students are being calculated, which is 17% and 2% in group B, and the absolute risk difference is just a minus of the two risks compared with 1 and the 2. So you get a value of 8, but the risk, relative risk, is the risk ratio, which is divided the two risks, but you have to be careful which is going to be the denominator. Now, one normally gets scared of statistics, but there are some softwares available. As you can see here, simple method is there. Just put in your figure and automatically you will get all your results, including your odds ratio and risk calculation. These all can be done very easily when you have such software. So one doesn't have to be really be afraid of the statistics which are there. It can be easily be seen that you have to just log in, change the numbers. As you change the numbers, the figures also will change. You get the confidence intervals, you get the chi-square test, you get the relative risk, you get the odds ratio, and even if there is a diagnostic test evaluation, that also can be done. So all these proportions and can be done on the software. Prevalence of binge drinking was done between the first year and between first 3 years and fourth year in both males and females. And as you can see, male drinking was much more in the later stages, that is the fourth and fifth year, whereas in females it was more in the first year. Binge drinking in the males, 1% more likely to binge drink than in fourth. So here what you are trying to do is you take the sample size. True population prevalence, core theme of is of the uncertainty. How to do is that the bias production, the spread of the around the mean, that is to be seen, and sample error which is there. The smaller the sample size, larger is going to be the error, and this is the foundation for evidence based, because you want to see whether the results which you have found are proper or not. So you have to find out how much amount of uncertainty is there, and that is by your p-value, confidence interval and p-value. Confidence interval gives you a range within which that particular true value is present, true prevalence is present. So in this particular case, it was 55%. So confidence interval was between 48 and 62. So between 48% and 62% is your true prevalence, which was 55. So, but it gives you a range. The confidence interval can be easily be calculated. The lower limit as well as the upper limit using the standard error. So you need to take the standard error, and applying this formula you will be able to easily get what is the exact prevalence rate which is present. If you can see the calculation for 198 students, 51. Now you can always find out what is the average this thing. For example, in this particular case, if you are taking 50 as the average, you see most of the articles are within that limit. When you even the most conservative estimate of cannabis use was 48% of all dental students which were currently using it. So if you have taken larger standard, the standard error is become the confidence interval becomes narrow, whereas in a small study the standard error, because that is how it is calculated, becomes low. And as you can see here, the lower two second last and third last results are much away from this. So this is what creates an error, and this error is what doesn't give you good. And that is what is bias all about. Bias is the influence that result from a study and is systematic and either overestimates or underestimates. Now, bias can result because of the student character, the patient characteristics also. The people characteristics is what will decide. Some people will respond somewhere, some people are. Bias should not be considered with random or chance variation, which reflects from natural differences between people. People are going to be different, they are not going to be all same, and that is why that difference is chance. But bias is something which you do it wrongly. Sometimes the bias can occur because of the background culture. Some cultures, for example in this case, may not be allowed to take alcohol and drugs. Sometimes there is misinterpretation of the habits because the response of your participant might be wrong. They might be lying, and because of that you will get wrong information. So underestimating and shift in one direction is always possible in such cases. Bias can also be because of observation. If you are using non-experts to do your observation, then also that can be created. Investigative, if your questionnaire is not validated, that is why normally whenever you use questionnaire, you have validated. The strength as far as this, that it was students of 5-year study, so all the students were followed for the 5 years, and that was why comparison was, so that was the strength of this. The questionnaire was anonymously given, so that we expect that there will be true answers, because nobody is going to ask them why you are doing this. And students were asked to report how much alcohol they consumed the week previously to completing the question. That means it was not only the current one, but what was normal pattern which was there, that pattern was being brought out by the questionnaire. And that is where the strength of this article actually rested, because it gave you a comprehensive 5 years comprehensive, it was anonymously given, and it was well done. The questionnaire was piloted on 25 students beforehand, and that is why the questionnaire also was prepared, and that was a great strength as far as this article is concerned. And the response rate was very good, because it was a closed group. It was in a college where you could go personally and get the information from the student. That was the strength. Smoking habits before and after the entry in the dental school was also taken, so that what was their average before they entered dental, and whether because of dentistry the drinking was more, that could be found out. Title of the paper implies an interest in habits of dental students, but it was only in one particular university. It was not all the dental students in the entire UK. The dental student had a high proportion of ethnic groups. That was written in the discussion, which means some people may not be taking drugs and were included in the topic. The results were went after some time, so it may not be the current results which are there, and self-reporting was there. So which there is some amount of inaccuracy will always be there in such cases. The characteristics of the 24 students who did not respond in this particular article was not known. So that was where the consistency would go down. So the results, and if you compare with the general household survey which was done in Great Britain of the same age group, it was very high, 42%, 35%, compared to 10 and 5% in the dental students, which means that this in dentistry itself there was not so much amount of bad effect. So take home message is, look at the aim of study, the sample, potential biases, strength and limitation of the study, and the results which you have to apply. This is what evidence-based education system is all about. Because when you read an article, you have to see whether it is applicable. Let us go ahead and go for a measurement of people, and for that we have taken another article on whitening toothpaste. Different types of toothpaste which are there, which were utilized. Now, there is normal in people, there is natural variation, and that is why in this particular thing, acrylic plates were utilized, because it was an in vitro study. Different blood pressures, different characteristics of the patients, that variation, natural variation is always going to be there. And this study also followed that same natural variation. So they compared the effectiveness of several whitening paste with a regular toothpaste and water alone. And that is why they were used 30 acrylic teeth specimen which were utilized, and measurement of the stain which was retained was seen after 5 minutes, and the measuring was done by optical density units, which is a very standard and methodology and more objective in nature. It is not subjective in nature, so it was objective in nature. The study design, it compared 7 experimental formulation, 1 regular toothpaste and water. Acrylic specimen were used, and they were soaked in human saliva for 2 minutes, and then with 2% chlorine, and then the whitening was checked. Toothpaste was then applied. This is this methodology. So if you go through the methodology in evidence-based education, you will know whether it is introducing any bias or not. So as you can see here, there was every step it was very calculated. Now the result which was there, optical dentistry was then tabled, and the percentages were then calculated, and the whole total also was percentage was also given. The area of staining after staining was measured. Optical density units were utilized. The range was from 29 to 90 optical units. Toothpaste, the same toothpaste was used in all the specimens. The effect on the acrylic specimen varies according to the specimen itself, and this was mimicking how the difference in the people also, if the people is different, the acrylic also will be different. The efficacy of the toothpaste was then calculated, and how far the data was spread from the center, that was seen, so that you get the average, and from the average, so whether it is a normal curve or not, that the mean, whether the spread across the mean was perfect or good or not. So they describe the average and the spread. The number of scans in a particular averaging was done according to that. The shape of the data, we use the number of table to draw the, and then you draw the histogram. You take a bar diagrams and you get the, for example, there are 5 observations in 40 to 49 optical density after 5 minutes. Then those will be grouped together, between 40 and 45, and that is how this bar is created. And as you can see, the most of the are in the center, that is the longest bar which is there, which means, and there is a slow spread outside, so you can create a histogram, and a normal curve is possible. The mean is then calculated. The sum of the measurement was 1693, and there were 30 observations. So that a mean optical density was 56.4 as going. So then you find out how much of these are in the 56.4 range of density, and how much are away from it, and how far they are away from the 56.4. So that is how you find out the results are okay or not. And when you do that, what we can do is we can start comparing results. For example, you want to know which MacLean student is better than this, then you go for the standard deviation. If the standard deviation is less, that means the results are okay. This is how you start comparing, and this is what you want to see in evidence base. Conducting a basic sample of survey, you have to, when you do the sentence, if you take a new drug, whether pain elevation is there, we test on a sample, but we want to know if the drug will perform good in the other children also in the future. So that is why we study the population of all students. So whether it represents other children also across the world, that is more important for us to see. And that is why you want to see the different results which are there. As you can see in lower, the values are much away from the mean values. So those samples we should not take into consideration. So if they are present near the mean, so sometimes it so happens that they don't spread to them, and the results are skewed. It is not a normal curve. Then in this condition we take the median. The median is generally utilized. So median is going through interquartile range, and that is how you get the median. So you get the 25th interquartile range, the 75th interquartile range, and between this 25th and 75th is your 50th person, which is your median. So you calculate the median instead of the mean when the results are skewed. This is what you should see in the article, whether the key points are really well mentioned or not. Measurements of people involve natural variation. The mean and standard deviation are used if the data is symmetrical, that is normal. But the median and interquartile range is used when they are not normal. And confidence interval for a mean provides a range within which the true population mean is likely to be. So this is what, so now let us go for comparing groups and association, finding association and correlations. Investigating a new treatment or cause of oral disease involve comparing characteristics between two or more groups. We cannot tell if the treatment for say periodontitis is good on the people unless you are able to tell how effective it is for people who have not taken the periodontitis. So the difference which is there, you have to cut out the baseline first. The comparing two proportion which we generally do, now the paper which was Underwood and Fox, we are going to use the example of the same. So in the binge drinking which was there in the female, in the first 3 years, and if you compare, then you can give a result. Okay, yes, in the first 3 years the females were drinking much more than in the 4th and 5th year. These kind of comparisons are to be taken when you are taking the risk differences. So if you compare between the first 3 years and 4th 5, it is 69 by 39, that is 1.8. That means you can project that they are almost twice as likely to binge drink in the first 3 years than in the. So what is most important is what is the denominator. In the year are twice more likely, you need further information. So it is better to say is more likely to do. Instead of going away straight away saying twice more likely, you have to say that it's compared to the 4th. So you are getting a reference group. you are referring that comparison to a particular group, and that is how reference is to be gained. And you have to be careful how it has been worded in the article. In this case, the percentage of the female student would be same in both the groups. The relative risk if the binge drinkers were related to the year of study, then it would be the same. So then the relative risk would be no effect, because the population is the same, and that is why the difference will not be there, right? The obsolete risk difference which is there is then calculated. So 69 minus 39 is 30%. So 30% more female invalid drink than those who are doing in fourth year. If there are 100 female students in year 1 3 and 100 in 4 5, the population will remain the same. An extra, which would mean that an extra 30 would binge drink in year 1 and 3. The reference group is most important. When the reference group changes, your results will be either in the positive or in the negative. And this is then interpreted in a different manner. The minus tiles tells us that 30% fewer students in 4-5 who binge drink than comparison to them. So where you say that 30% more people are drinking, here you are saying 30% less people are. The relative risk only indicates the magnitude of the effect which is there, and not whether the effect is beneficial or harm. So that beneficial or harm will depend on the positive and negative risk value. If the outcomes are positive and the percentage of children who are caries free, a relative risk that is greater than 1 indicates benefit. But where it is less than 1, it would mean harm. If the outcome is negative, such that the percentage of the people are dead or the percentage of people who experience pain after oral surgery, a relative risk greater than 1 indicates harm. So this is how, depending on whether it is beneficial or harm, is depending on your research design, and evidence based really looks for that. So here you can see that it is always better, instead of just taking the risk difference, which is the minus of first and second, you always take a risk ratio. The ratio actually nullifies the bad effect of giving wrong information, and that is how we talk like this. The outcome measures which are there, say suppose you are taking 2 antibiotics, then the relative risk is 1.3, so that antibiotic A is better than antibiotic B. On the other hand, there is 40 to 50% difference, then the treatment C is worse than treatment. See, your method of interpretation becomes different from error. So the true risk difference is based on the standard error. The sample of female students of the same size risk difference are likely to vary by an average of 10%. The standard allows us to construct a confidence interval, and confidence interval is what you have to see to it, that in this case it was between 10 to 50%. Now if you take the binge drinking in females in years compared to 4-5, the obsolete risk difference is 30% with confidence interval of 10 to 50%. But the relative difference is 1.8, which is 1.1 into by 2.8, which is getting a slightly narrowed. So always try to use the relative risk or risk ratio in your article, rather than going for risk difference, because that might give you a false sense of confidence. The confidence interval is wide. It is in the summary. We need to have a statistical set to get the comparison. So whenever you have a large confidence interval, you go for finding out the p-value, and then that is done by the chi-square term. The prevalence difference, depending on the sample size, will give you the p-value. The larger the sample size, the p-value is better. The smaller the sample size, the p-value might vary. So you have to, the findings which you are going to get should be statistically sound. The p-value associated in the difference of 30%, that is 69 and 39%. The percentage respectively was 0.003. Right? So that is what gives you the p-value. And if the on the female students in the UK in 19, there was no difference at all between the prevalence of the binge drinking between the years of the study. The true difference would be zero. That is, there is no effect value. That is the final conclusion of this particular p value. If there is no effect value is zero, and this is how you interpret that. So if your p value is less than 0.05, then there is likelihood that the real effect is there. If it is more than 0.1, then it is less likely that that effect is basically because of the drugs or whatever you are given, but it is more because of chance. And as you can see, the difference between the two proportions, absolute risk difference and the relative risk difference, the results are much better when you are taking relative of the two populations, and the effect value becomes 1 because you are using ratios. So always go for ratio rather than going for the difference, because difference may sometimes give you a wrong number. So if it is unlikely to be 1, relative risk is unlikely to be 1, there is likely to be effect. If we do not have and if it is less than that, then we do not have enough evidence to say that there is a real effect. The alternate interpretation of relative risk can be expressed as a percentage change in the risk. That is easier to explain, because visually and thinking wise, it is much better to have this. The percentage change risk difference between the two risks as a percentage of the risks in the reference group. So you take the reference group, and what is the change to that reference group, that is what you want to see. So if you the risk difference was say 20% in group A and 50% in group B, then the risk difference we say is minus 30. The negative sign implies that the risk in group A is lower than in the group B. The percentage change in the risk reduction 60%, that is minus 31 into 100. This can also be calculated directly from the relative risk. So then your results become more appropriate. The relative risk of group A compared to group B is 0.05, 0.4. So you get is minus 6. The risk in group A is reduced by 60% compared to the risk in group A. Similarly, a relative risk of 1.35 can be interpreted as an excess risk of 35%. The risk in group A is increased by 35% compared to the risk in group A. Every statistics gets interpreted by the way you want. Be very careful to find out whether you are being given wrong information. The interpretation should be perfectly matching to the statistics which has to be utilized, and that is what evidence-based education is all about. When the relative risk is greater than 2, then the calculation becomes huge. For example, in lung cancer and cigarette smoking, is about 20. This would mean that 1,900%. The same thing could be represented as 20 minus 1 into 100, and that gives you a saying that it is 20 times more. The interpretation becomes that the relative risk is 2, or it is the risk is 20% more in those people who are smoking and having lung cancer than those who are not smoking and having lung cancer. This is the difference which you can do when your thing is very large. Coming back to your our tooth whitening, so all this question which is there, Booth's advanced whitening is better than Beverly, or Maclean's is better than water, pearl drops are better than water, Colgate is similar to the other Colgate regular. All these questions can be answered by using the mean, standard deviation, number of specimens, some study number which was there. All this can be calculated very easily, and you can compare by comparing the means and using a graphical system. when you use it graphically, your comparison becomes very easy to find out which is better and which is less. So this is how comparisons are there. The observed, but we have to find out whether the observed difference is a chance finding or not. The mean area of stent remaining after 5 minutes, the mean value was 30.1 and 71 optical density. So 41 units respective difference was there. So for that you need to go for a t-test to find out whether it is an actual difference or whether it is a chance finding which is there. So that t-test also gives you the p-value, and once you set that, the p-value would tell you the difference is less than 1 in 1000 patients, that is 0.001. Then in that case there is a strong indication that the results is accurate. The smaller the p-value, the more certain we are of the effect. So less in this sample it was 0.001, it was much less than 0.0, and that is why it was much better. So associations and measurements which are there are two questions we wish to answer. If we know the man's age, can we predict his blood pressure? How strong is the relation between blood pressure and age? So whenever you want to find out association, we need to find out the association by what is called as linear regression. So you point out the between the systolic blood pressure and the age, and you will find that the points are distributed like this. Now a central line can be drawn through this, and that is called as a regression line. This line is called as a regression line. So the systolic blood pressure at the age of 70 is 1.7 into the age. So normally we would be able to calculate the from that graph what would be the normal blood pressure for that. So for 50 years it is 156 millimeter, for 60 it is 71, and for 71 it is 173. Now the blood pressure increases with age, so the slope of this line is upward. So regression coefficient has a positive value. If the regression line slopes downward, that means the value of one variable is decreasing as the value of the other. For example, people have lost their teeth. For example, teeth, as the age grows, the number of teeth are lost. So that would be a negative. So the regression coefficient would be a negative value. So this positive and negative is on the regression. Correlation is generally found out by doing this regression analysis, whether the blood pressure is really associated with this, and that is how you get this. If you get this kind of perfect line, that means there is positive correlation which is there. Because as the age increases, the blood pressure will increase. The correlation coefficient summarizes the strength of the association between the two variables, and this ranges from between 1 and -1. So if you are closer to 1, then it is positive. If you are closer to -1, then it is negative for the systolic blood pressure. So if you see the R value, that is the correlation coefficient generally called as the R value, and this positive value of R, that means the effect is there. The p value is less than 0.1, so it is extremely unlikely that it would be by chance alone. So normally what we would do is we take the square of the correlation coefficient, that is R square. It tells us how much variability in Y is explained by X. The correlation coefficient between systolic blood pressure and age is 0.89, or R square is 0.9. This tells us 79% of the variation of systolic blood pressure is explained by age. There might be other reasons also, but 79% is because of age. So whenever you are treating a patient, you know that the age is a factor to be considered when you are giving treatment for blood pressure. And these are the different types of graphs you can get, where the correlation is 0, or whether there is a positive correlation or a negative correlation depending on the slope of the graph. So association causation, you have to be careful. Association does not mean it is cause. For cause, we have to go for a much more rigorous analysis rather than association. Association can be very easy. Now, for example, here the blood pressure and age, we have found the association, but we cannot say that it is the cause. Because the weight is also important. If the patient's weight is there, his blood pressure also will increase. So, what does effective actually mean? Is it a percentage reduction in the number of, for example, if you are taking ulcerated gingivitis, within 7 days, the number of patients who fully recover, is that the measure? Do the result effectiveness of metronidazole of the drug is good enough? These are the questions which are clumb. Is it because of the drugs, or whether it was fluke? The specific aspects of clinical trials are basically based on how good your clinical trial format is there, and that is why randomized controlled trials are supposed to be the best as far as clinical trials are concerned, because it contains randomization, it contains blinding, it contains control groups, and which patients are to be included and which are all very well specified. And this is what gives you a much more rigorous and controlled atmosphere of the study, and that is what that is why it is higher up in the hierarchy. The randomized reduces bias. Researchers also doesn't know, the patient also doesn't. The mean difference in the outcome at the end of the trial should be attributable to the treatment and not to any other factor. This is what randomization does. Blinding, on the other hand, which reduces the patient and operator bias. So that kind of bias which is there, and there is objectiveness which is there, because it is controlled trial. The reference which has been given is by Everly and et al. What is the specific aim of the study? The main aim of the study is whether patient was given metronidazole, and then they were divided into 3 groups. The one group was given nitrous oxide, the other group was given nitrous oxide and servoflavin, and the other version was just giving air. Now, ethical part of that, giving air is good enough or not? Yes, it doesn't cause any harm, so that can be done. The inclusion and exclusion criteria specified everything. What was the age group? What kind of questionnaire was used? What scale was being used? Whether everybody had the same cream applied, and whether the history of hypersensitivity was taken or not, which was an exclusion part. So if there was hypersensitivity, this patient was not taken. So this is how study is conducted. It was a double-blind controlled randomized trial, and that is why it was the allocation which was done was totally random, extra, because it was done by a nurse who was not involved in the entire study process, and the anesthetist had to be told, okay, what is to be given. So anesthetist was told, but the children did not know. So as you can see here, they have also controlled the sex stage, they have also controlled the anxiety stage, because these are the variables which will cause the effect on the results. So blinding was done. The author mentioned that servoflavin had a sweet odor. So some kind of bias can be in that. The control arm was given medical air and metronidazole, and this was acceptable, because without giving air also treatment can be done, or without giving the servoflavin or this can also be done. So there were 2,358 students who were eligible. 848 of them were randomly randomized and into the 3 groups were done, as can be seen in the figure in the article. Intervention arm had a similar number of patients and the trial, so there was a good comparison between the groups, and this was early analysis of the result showed. And normally in evidence based we need to know how the randomization was being done and what was the procedure followed. This tells you how good that particular results would be if the randomization is done properly. What kind of allocation is done and the method of doing the analysis, how much have been analyzed, whether there was any loss of patients. What were the main results? Because the comparison between nitrous oxide and air, nitrous oxide and sulfofluorine with air, and nitrous oxide with sulfofluorine plus nitrous oxide together. So these were the three groups which were actually measured by this study, which was there, and the results which are given here, and the outcomes which are there. Secondary outcomes also were evaluated. The perception of the children was also taken into consideration, and for the standard unit. We found that 0.54, that means half the children in group 1 completed the treatment. About 9/10 of the 90% of the student of the children completed the treatment when given servofloxacin and the nitrofloxacin. So nitrous oxide. So this kind of data was created here, and we could find out that nitrous oxide and servofloxacin had the best results compared to nitrous oxide and air, and compared to the other two. So whenever there is a large trial, small standard error, narrow confidence interval, precise estimation of the effect, and firm conclusion, the results are always much better. The 95% confidence of the study in different groups can be seen here in the study, as you can see. Even they have projected if the study had been done with a different, what would have been the effect. As you can see here, the relative risk difference and the confidence interval gets narrowed with an increase in the number of patients in the study. As you can see, coming back to it, what is most important is the number needed to treat. This number needed to treat quantifies how many patients have to be given a new therapy so that one extra patient benefits. Normally in therapy, harm, prognosis and causation, we need to go for number needed to treat. Otherwise your results will give you a false impression, and that is how and what we have to do is find out whether you are going to do relative risk or whether you are risk differences always will give you a slightly larger effect than it was normally present, and relative risk generally gives you a much better and it can be generalized to the population, relative risk, whereas risk difference is for a particular group of patients only, and that is why risk difference is better. Now, is it by chance? Is it the p-value less than 0.1? There is the possibilities are that there is really no difference. There is a real difference, but chance we have picked a sample that did not show this result, and the real difference, but the study was too small to affect it, and that's why the chi-square test which was done with the p-value which is done tells you much better that it was a chance effect or whether it was a real effect. The impairment could be missed if the decisions are based solely on statistical. You have to see the clinical effect, the effect size which is there, and the confidence interval. That is also are the most important factors. Just statistical significance, taking the p-value, may not be the correct method. You have to go for confidence interval and find out the effect size. The power to detect is what we have to, the research is based on, and large sample size is what is required. Both clinical importance and statistical significance, both clinical significance should be considered. Reported results on successful cannulation, which was given. The people where the cannulation was done, the odd ratio, which is similar to relative risk, was different. So this is how you, in evidence-based, the p-value is, if it is not far from 0.05, the whole sample of nano was effective. So it is possible that it is also effective in the subgroup of children who are cannulated. In a situation where the confidence interval indicates that there may be clinical useful effect, the study is too small to have a power to detect it. Further research based on larger population is required. This is how you interpret all this. Side effects and safety was also taken into consideration. People who were taking servoflavin had vomiting effect because there was excess amount of depressing sedatives which were given, and that was shown, but that was easily managed. The side effects which was there could easily be managed, and that's why there would not be much harm in going ahead. How good is the trial design? There was randomization. Study size current time was large enough. There were 1,000 students, more than 1,000 students, patients. The calculation of the sample size was done by power calculation. So small pilot study was done, which is again a very good thing which is to be done. Every research should be first done with a pilot study, and the sample study should be calculated from that pilot study depending on the effect size. How much was the compliance? 70%, 84% and 83% was the compliance, which was very good. Lost of baseline characteristics of the subject, lost to follow, are often reported and published in the papers, and this should be taken into, always to be taken into consideration, because the results on those dropouts will vary your results, because you are taking average results, right? Now there was a study which was done between surgical group and chemotherapy group for cancer, and the survival rate for 50%. Now there were some people could not be done surgery, so there were dropouts. So how do you handle this? Either you leave out the inoperable patients and do the study, add the inoperable study to the chemotherapy group and then calculate, and leave the inoperable patient in the surgery group itself. But doing that in the third group will reduce the effect of the surgery, whereas the chemotherapy will remain the same. Increasing number of patients in the chemotherapy again will give them. So there is a balance line which the researcher will take. What is to be done depending on what kind of cases are there, depending on what kind of research you are doing, the researcher will do that. Patients who received their allocated treatment, that is comply, then that particular research is called as per protocol analysis. Means you are taking only those who are complying to that, and which creates a kind of a bias. So if the criteria are fulfilled, then it increases our confidence. The trial was randomized, controlled and double blind, so high proportion of children received their allocated treatment. There was no losses to follow. The sample size was based on the so this is how you have to calculate on evidence-based education system. A possible weakness of the study was the result was based on per protocol analysis, which means that there were only positive results were taken more into consideration. So the results could be, so re-analysis with the intention to treat basis should be done. Before when you start, the intention to treat basis should be calculated, and then, so you have to see into the article whether the intention to treat basis analysis has been done, or whether per protocol is done. Whether it contributes to your practice, that is to be seen. What is the clinical importance? how, who will it be applied to, which is the representative problem, what is the cost benefit analysis of the treatment and the potential of harm, if you have to see the balance between the good effect and the bad effect, and what is the whether the increased financial loss which the patient will suffer is good enough for the kind of benefit which you are going to get. If the benefit is not too high, then going for something which is more costlier just because it is statistically better need not be there. Let us take diagnostic research, and diagnostic research will need to be looked into in a much different matter because you are doing different kind of. The requirements for a good screening test would be: disorder needs to be well defined, medically important. There should be effective treatment or preventive measure. Prevalence or needs to be known and judged sufficiently high. Prevalence should be known. The test should be safe, easily implemented, and widely available. And the performance should be values should be between the affected and infected. There should be very little overlap. That means the type 1 and type 2 error should be as less as possible. This is what a screening test would be named, and the reference which we have given is Downer and et al. Oral cancer, for oral cancer. The screen positive and screen positive, normally what we do is give a 2 by 2 diagram like this. On one side there is results of the screening test, and on the other side is whether those patients were having disease or not. This is called as a 2 by 2 table, and you put in the level, and you have A, B, C and D already written there, and by this you can do a lot of more calculation for your diagnostic purposes, and these calculations are very important. So 2 by 2 table should be in your mind. So in this the screen you can see that screen positive, the risk is now 17 prime. So increase from the basic risk was 5.5, and the risk has increased to 71%, which means that there is a positive. But if it is a negative aspect, it is going below the limit, then the screen the risk is less. So if they do not have a positive result, that means they do not have the disease. This can be calculated in this particular manner. The detection of 71 is high, and the false positive is only very slow. That means this particular test is good enough for using as a screening test. A good chance of correctly identifying the people who are having the disease, and the people who test positive are in fact having the disease. This is what the test will signify. This is what is called as sensitivity of the test. If a certain disease is common and clinically a test that has detection of 40% and a false positive might be thought to be useful because it is a common. But if it is a rare disease like a cancer or something, then the detection rate, that is sensitivity and specificity, will be too high. Sensitivity will be too low, specificity will be too high, and that test is not as important. For example, if you are comparing toluidine blue with biopsy, then toluidine blue will have a lower. So when you do the diagnosis test, sample size should be done on the effect size, power and the significance level. All these three, which are taken from the pilot study, will decide what would be the sample. The pilot study and the previous studies which have been done will tell you the size of the effect. It tells you the power also, and the significance level you can decide at 0.05, and that is how sample size will be determined. The effect size that we choose our sample is often based on the previous knowledge, that is previous this thing, and that is how significance level 95% or 0.05 is calculated, according to your previous articles which are there on the same topic, which and what the other researchers have found the effectiveness. That is what guides you in getting your significance. Power is defined as a chance of detecting a specific difference or effect size if it really exists. The power, which generally we should keep it as 80 to 90%, because then we are sure that the whatever is being detected is the effect size. So effect size generally denotes the power, and that is what is important. The aim of the sample size estimation is to provide an approximate size of the sample. An effect as the effect size, that is the difference, goes down, harder to detect the small differences. As the power goes down, decrease the chances of picking up a difference. As significance goes down, decrease the chances of seeing. So in all these respects, you have to see that the effect size is very high, power is high, and the significance is also appropriate. For example, in this particular study where gas and air was given, you will find that in this particular case, as the confidence interval reduces in this particular patient, the effect size and power size also reduces. The sample size also will reduce. So the take-home message is: observation studies use random sampling, clinical trials use random allocation. Both case control and cohort studies are give you a little confounding. Cohort is better than case control. Clinical avoid bias and confounding through the basis of randomization. So always try to go for randomization wherever possible. But if not possible, you can go ahead for cohort studies or case control. But you have to take it with a pinch of salt, because you know that there will be confounding effects. So you can get approximate effect, but not the correct effect. So understanding of the p-value and the importance is important. Confidence interval should be utilized always. Effect value of the comparison should be there. No effect value for comparison should be taken into consideration. Risk ratio, risk difference and odds ratio should be always be taken. Chi-square test and t-square, depending on whether you are using the means or you are using standard deviation and error, that should be done. And R-square correlation coefficient should be there, and that will tell you the effect size. So all these different statistics which are there, it tells you that yes, this particular article, whatever has been results have been projected, are good enough and can be utilized for your patient or for your research. This is what the statistical importance is there, and statistics you should go. You need not do the statistics yourself. There are many softwares available, and so it is very easily possible. And all this can be utilized in your journal club. Instead of just reporting effectiveness of a particular thing, go for a critical evaluation. And that is what evidence-based education system is all about. That whatever you critically evaluate, whether you can utilize